Clinical privileging and its impact on patient safety. I'm Yashashri Raghuvanshi, and I welcome Dr. Usha Manjuna, Director IIHMR Bangalore, Dr. Kirti Uday, Associate Dean Academics and Student Affairs, Dr. Piyush Kumar, Associate Dean Training, along with a very esteemed guest speaker for today's event, Dr. Mahesh Patel, along with all the online attendees of the event. I would now also like to call my co-host, Dr. Shreya, to sensitize us briefly about patient privileging. Shreya, over to you.
Yeah, thank you, Yashashri. Class, before we move ahead with the sir's presentation, and so I'll just brief you about, just give you an insight about what is clinical privileging and credentiality. So clinical privileging is the process of authorizing a licensed or certified providers a specific scope of patient care services. This process is performed in conjunction with credentialing and includes the evaluation of an individual's clinical qualifications or performance. And the credentialing is a formal process that utilizes an established series of guidelines to ensure that patients receive the highest level of care from healthcare professionals who have undergone the most stringent scrutiny regarding their ability to practice medicine. So these both are important because both are necessary before a physician is permitted to practice alongside credentialing. Privileging authorizes a licensed or certified healthcare practitioners specific scope of patient care services and evaluates an individual's clinical qualifications or performance. Over to you, Yashashri.
Thank you, Dr. Shreya. And now it is time for our guest speaker, Dr. Mahesh Patel, to take over from us here. Dr. Mahesh Patel presently is associated with Aster DM Healthcare as a Senior Manager, Operations, Facility Licensing, a new initiative with more than a decade of experience in the field of healthcare. We welcome you, sir.
Thank you. Students, if you have any questions, please put down your questions in the chat box. That will be answered later. We welcome you, sir.
Okay, thank you, Shreya. And so I would like to share my screen.
Yeah, please.
Yes, sir.
Okay. So it is visible, my screen is visible. Can you confirm, Piyush?
Not yet.
Not yet. Yeah, I think now I'll be able to share.
Yeah, it's visible. Perfect.
Yes, sir.
Okay, it is full screen, right?
Yes.
Okay, thank you for first of all for inviting me, and pleasure to take a session, and thank you for such a nice introduction. And already Ashish, we have briefed what is the clinical privileging and implication on how it is important in relation to the patient safety. Though this topic look very simple and very less we hear from in any such forum to discuss on this topic, but has a lot of impact on the organization, on the patient, and as a overall in a global burden from WHO point of view. So I would like to start from what is the global burden of adverse event if we look. If we look, approximately 42.7 million adverse events results every year. It may be from the bloodstream infections to the hospital-acquired infection to the patient fall, wrong side surgery, or anything which could have been prevented, harm which could have been prevented, and which has resulted due to the care process. And if we count on the daily basis, there are almost 116,000 adverse event results, and if we count it hourly, approximately 4,874 adverse events results every hour and 81 adverse event every minute. So you can imagine the severity of this problem. And by the time we will finish this session, probably another 5,000 patients would have been harmed globally. So such a big issue it is and concern, and every time, every forum emphasize how we prevent that, and because whatever we damage to the patient harm in terms, it cost obviously, because to restore the health of the person which is harmed because of the wrong side surgery or because of the infection and other reasons. Now, what is the estimated cost of patient harm per day is 2.7 billion. It is a huge amount, and it is probably the percentage spending of healthcare of some of the countries. And if we count in an hour, it is 114 billion are being spent on global preventable harm. So the cost and also the magnitude of problem is very large. And both coming to the topic now, privileging. So as mentioned, that credentialing and privileging, these both are very closely linked in terms of patient safety. So without proper credentialing, the privileging cannot be done. And if we grant the privileges without proper credentialing, it may not yield the results and may lead to the patient harm and may expose organization for any litigation or any risk. Now, though definition has been brief, but I would like to reiterate on the definition that what is the credentialing? It is the process of obtaining, verifying, and assessing the qualification of a practitioners to provide the care or service in the healthcare organization. So we are verifying here. How do we verify? What are the guidelines and different state or national or accreditation bodies says how we should do the verification? So all have echoed in the same terms and the language that it should be the primary source verification. Now, what does this mean? When I say primary source verification, we keep hearing that, but it means that we verify the credentials, be it an education qualification of the practitioner, be it experience, or be it the recommendation or reference letter, should be verified from the origin issuing entity. So if you want to verify the doctor's qualification, it is preferred that we do it directly from the university which is issuing or the medical college which is issuing. If you want to verify the experience of the experience certificate or the logbooks, that how many number of procedures are being done by this doctor, we verify from the respective hospital. Or in case some reference has been made for the recommendation or reference has been made, we verify from the person who has issued this reference. Now, why it is so important and so much of emphasizing, and as I told you and would like to reiterate that, it lays the solid foundation and evidence-based decision regarding granting the privileges. If credentials are correct, it lays very good foundation on the basis which we can grant the privileges and allow practitioners to do procedures or care the patient in the organization. Now, typically, who does the primary source verification? In an Indian context, we are discussing. So most of the time, medical director's office and the HR team collaboratively work together to verify the credentials of the physician or the practitioners whom we are recruiting. But yes, there is a large challenge remains across the globe, including India. If we are recruiting the physician from other geography, including I'm talking if we are recruiting from even other state of India, from Maharashtra, if we are recruiting doctor for Karnataka, there might be some challenges in verifying the education, experience, and other reference checks from the primary source. And it becomes more challenging categorically and particularly when doctor comes from other country itself. It's saying that we are hiring a physician from the Canada or UK or any other Middle East or any other country. It becomes more tougher for any individual organization to verify the credentials. And even if we are able to verify, it takes a lot of time and energy to do that. But it cannot be ignored. It is essential part of any organization as a part of patient safety and risk mitigation that whom we are recruiting, we should know that credentials are genuine and it is correct. Now, to make it easy and to make it more reliable, there are a lot of agencies which I always prefer. There are a lot of credible agencies which are available, which are does this primary source verification and through direct university, direct organization, or the person who has issued the reference. So it is highly recommended that we appoint an agency who does on behalf of organization the primary source verification. Now, why I'm emphasizing so much on this, and you'll be surprised, there are a lot of incidents happen not only in India but across the globe where, and I will be discussing a couple of landmark cases here to know the magnitude of the problem and how it impacts the patient. Now, there was a Dr. Williams in the US. He claimed to be he's a cardiologist, and he was very renowned practitioner, but mainly he was involved into the research, simulation, and training, and very rarely he was involved into the patient treatment. And he was known and admirable faculty, and even given many sessions, and he has delivered many trainings and sessions, including in American College of Cardiology, American Medical Association, and he was able to get millions of grants for research and simulation training. But what turned out in 2009 that Hammond is not a cardiologist. Not only cardiologist, he was not even a doctor. By profession, he was a pilot in United Airlines. So, and this news was published in 2010, but Dr. William was able to fool the hospital for almost 15 years. So imagine the person who is not qualified is in your organization and working for the patient and training the doctors on how to treat the patient. In this case, it was fortunate there was no patient harm. Patient safety was not compromised because he was more involved into the research and training, and he was more training the doctors on how to work as a team and how to lead in case of crisis, and he was more into the grooming the doctors. So it was a fortunate, but it was an eye-opening case that how one can manage 15 years without knowing, and unfortunately no hospital did detailed credentialing check for this physician, and he was able to manage to work in a hospital sector for almost 15 years. Now, this is about the qualification. Now, equally important, I'm always emphasize only qualification is not important. There are three aspects to look into the credentialing part. One is the qualification, of course, which is the base that doctors having the degree and qualification to work. Another part is whether the experience which is quoted is correct or not. And third, most important is the reference. Person is qualified, person is having experience, but the person is appropriate or not. That is also equal important to verify. Now, this here I would like to quote example from the again from the US. Between this case was where anesthetist was appointed by the Cadillac Healthcare Group in US, and previously he was associated with the Lakeview Hospital. Now, Lakeview Hospital, where he was working as an anesthesiologist, he was terminated from his medical group when the Lakeview discovered that this anesthetist is diverting narcotics for his own use, and they terminated. And Cadillac appointed this anesthesiologist. And when reference check was sent from Cadillac to Lakeview, the Lakeview gave the generic reference about the physician. They provided the only service date and notion that other information was not available, and due to the large volume of inquiry received in this office, we have given the reference that that physician was good. But Lakeview was very well aware that why they have terminated this physician, but they didn't provide correct information to Cadillac Healthcare. Now, what happened? The anesthesiologist who was working in a Cadillac, he was involved in one of the tubal ligation surgery, which is very simple, but result of surgery went into the very horrific outcome due to the gross negligence of anesthesia, and that led to the massive brain damage, and patient was left paralytic. And he at that time he was working under the influence of drug, that's narcotic drugs. And upon investigation, when it was found that, and when case was going on between the court, when patient sued the Cadillac for negligence and providing resulting harm to the patient, and a claim was settled at 7.5 million between Cadillac and the patient. Now, what happened about the Lakeview? Later on, when Cadley came to know the reference which was provided was also fake and it was not genuine, and Lakeview was very well aware about the case, about the person. So here, the cost of silence in medical staff, which we always say silence is a golden, which should not be longer apply when responding to the question from another provider for credentialing information regarding the previous affiliated practitioners. Organization has the responsibility to provide genuine and correct information to the next employer. And list is so long. If we quote the recent examples, this is the example where fake doctor in the James Shinley was fined for $13,400 for working as an unregistered practitioner in Sydney in 2021. This came in limelight in January 2022 only. This is because of the pandemic, lack of time. Many practitioners were been appointed, but verification was not done. But upon verification, particularly case came in limelight. Again, there is another case would like to go quote here. In Germany, the fake doctor was arrested for resulting 4 anesthesia deaths and found that doctor was not having adequate qualification to give anesthesia and work as an anesthesiologist, and his credentials were fake. Another example I would like to quote here, where you are based in the Bangalore, where leading hospital, corporate hospital, where they were not having any clue that fake doctor was working and examining the patient for almost 5 years. So list is very long. If we search, there are long list of such examples, which is eye opener, and it is happening across the globe. It is not a problem of any one specific country or state. It is a global issue that there are a lot of such incidents are happening still, and it needs attention now and as well as in the future. Now, when credentialing, when we are doing, it is a process where we verify the qualification, experience, and the reference. We should red flag certain things if we find, and we need to deep dive if we get either of these things when we verify the credentials. First, either we do it in-house or whether we get it done from outsource agency. Now, there are 3 things can come up. Either credentials are been mentioned as a verified, or it is unable to verify, or it is a fake, or it is not a genuine. These 3 things come up. But when it says when they are unable to verify, it doesn't make a ground to not to recruit that person, but that flags that certain further investigation is required in this case. When agencies or when during self-verification, when we find yes, it is verifiable, then we don't have any issues. But when it says unable to verify, yes, it need to be examined and deep dived in detail. Also, when we see there is any break in the practice and there is a frequent gaps among for the physician whom we are recruiting, again, it need to be investigated why there are breaks in the practice, or there is any frequent job switch or lack of logical career progression where physician is switching the job from one hospital to another hospital, and with lack of logical career progression, this need to be looked into. Though his qualification and experience may be genuine, but why he is doing, there might be something like which we have seen between Cadillac and Lakeview or healthcare. Now, average or generic reference when we get from the previous employer, from the HOD or from the medical superintendent or medical director, it need to be looked into until we don't get a satisfactory response or a reference. And of course, last 2 things are very important, that if we find there is any disciplinary action taken against the practitioners in the past organization or during education tenure in the medical school, or there are any malpractice cases and claim against the doctors. So these are the factors we need to red flag when we do the credentialing, and we find either of these things. It need to be deeply studied. I don't say again we should not appoint those doctors, but yes, whenever we find such points, it need to be studied in detail before we take a call whether we should appoint the doctor and onboard that physician into the organization. Now, this is the one aspect of the credentialing. Now, it is very essential we understood that credentialing is very important. So that lays the solid base to grant the privileges, because we are very sure the experience, qualification, experience, and the references are enough and are genuine in nature. So that gives us a good base to grant the privileges. Now, what is the privileging? If we look into the simple definition perspective, it is a process for authorizing medical profession to admit and treat patient and provide other clinical services, maybe medical or surgical, invasive or non-invasive, commensurate with the qualification and skill. So we are allowing any person, physician, to care and admit and treat the patient based on their past experience and qualification. Now, I would like to run one small quiz. Can we have a question, Piyush, on the screen?
Yeah, Yashashri?
So
I
would
to launch the poll. Yes, sir. The IT team is on it.
Okay. So I would to hear one question here. Can we allow all qualified MBBS orthopedic surgeon to perform total knee replacement? So you can answer your yes or no accordingly. We'll have a 30-second for this. Okay, we have adequate responses now. So if we can end this poll. Okay, so thank you. Now, if you look, why I have asked this question, and approximately 33% have said that yes, qualified MBBS and orthopedic surgeon can perform total knee replacement, and 66% have population have told that no, it cannot be. We should not allow them. Now, why it is important? Why I have asked this question? Qualification doesn't necessarily allow you to do certain things, though you are qualified. It requires competency. Now, if we take joint replacement surgery, be it knee replacement, hip replacement, or shoulder replacement, ankle replacement, these are the highly skilled procedures. So person may be qualified. Yes, you are right. People who have said yes, that person is qualified to perform the procedure, but he might not be the competent to perform this particular procedure. So there are two differences here we have to make out, and it is essential before we initiate the privileging process. There is a competency based on the experience, and there is a qualification. Qualification allows you to do something, but competency is essential to perform that procedure safely. So from my perspective, yes, it can be allowed subject to that person or the physician is able to prove competency that he can perform total knee replacement surgery. So moving to the next slide, and why privileging? If we look at the data from US, in 2019, there were around 5,225 adverse action were reported and were recorded against the physician. And if we take the count, where 4,521 actions were taken by the state licensing board, and they have United States has a different state. So there were around close to 85% actions were taken against the physician, and out of that, almost 15%, that comes to 704 doctors had their clinical privileges limited or suspended. So when I say limited, means they were made under supervision to perform, not to perform procedure independently. They have been made to do the procedures under supervision of senior, or the privileges was being suspended completely, that the practitioner is though qualified, but he is not competent to perform this procedure based on the adverse actions which were reported in just 2019. Now, if we look into this data and if we assume what will be the global burden, we don't know how big this problem is. And there are a lot of example from recently, what I would like to quote here one more, where there was a popular documentary movie which was released in 2021 naming Dr. Death. That was Dr. Christopher, who harmed almost 33 patients out of 38 he operated in a period of 2 years. And consequences were very bad in various patients where he operated. He injured the arteries, he injured the spine of the patient, he injured the nerve root. Why he was working under the influence of alcohol intoxication, that's what came from the peer group, which was not yet proven whether that was correct or not, but this was for sure that he has harmed many patients, and several woke up from the surgery unable to move from the neck to down and feel one side of their body is paralyzed. So a lot of hue and cry was happened when this incident came out in 2017, and court finally convicted him for maiming one of his patients and sentenced to life imprisonment. And why it was done, that he was working out of his conscience, and this shows one of the failure of the system as well, because a lot of his peer has raised the flags between the theater team, between the particular surgical department and the organization, but no one had a courage to report this. And also there is in US, there is a law that in case if you find any negligence from the doctors or any adverse event, it should be reported in the US Department of Health and Human Services. So it acts as a database which can be used by the next employer to verify the history of this doctor. But unfortunately, the cases which adverse event resulted from this particular Dr. Christopher was not reported into the national database, and due to the various loopholes in the system, it was not reported. I would like to say that, and which led to the doctor has hopped from one hospital to another hospital. But what happened ultimately, he has harmed many patients, and this is the result out of this case. Now, as I told you, magnitude of the problem of be it a credentialing and privileging, it is very difficult to ascertain at the global level due to the lack of data. We don't have the data from across the different countries, and there is no central data repository. All are based on the average assumption and values which are defined from the various countries' data. But it has a lot, yes, to do in the daily practice and huge impact on the patient safety. And it also affects as an organization, as a corporate, as a brand, and as a part of risk management. This both process should be done at the due diligence to ensure the safety of the patient. Now, as I told you, it is very important, yes, to protect the public from the incompetent practitioners, to protect the patient safety, to mitigate and manage the risk. It is most important in terms of patient as well as in terms of organization. If we don't do if we don't verify the credentials, if we don't do privileging, it is a risk to the patient as well as to the organization. So both credentialing and privileging helps in mitigating and managing the risk which prevails if we don't do the proper thorough process. And of course, last but not the least is complying with the accreditation and regulatory body. In various states, there are regulations how privileges to be granted. Wherever there are no regulations, there are accreditation guidelines which are available how privileging is to be done. So it helps in complying to this both the requirement. And thus, yes, the risk involved is very high if we don't credential and privilege patient correctly. Now, if we talk how the privileging is practiced in the different countries, including where I am based in India and different parts of the world, it varies widely. There is no standardized process. We have seen how privileges are being done. Practice is having huge variation. How privileges are granted from different country to country. Guidelines and processes are defined, and those are, I find it is acceptable considering the limitation of those particular country or geography and the kind of healthcare what they have. And some of them have defined their privileging system based on the national health strategy and need of the per healthy population. Now, just to give you a scenario of a few countries, how privileging is taking care. I'm emphasizing more on the privileging because credentialing is we have spoken, and privileging is most important part after that. And how does it exist in different countries? Now, if we talk in the India perspective, what this says is privileges are granted by the organization based on the committee which is formulated, and committee who grants the privilege to the physician as per the NEBH standard. We take that as a reference. If we talk from the Saudi Arabia point of view, privileges are granted by the organization, but yes, Ministry of Health has laid down very good guideline how privileges to be granted, on what basis it should be granted. Coming to the Qatar point of view, where I am based presently, so privileges are defined and also granted only by Ministry of Public Health. No individual practitioner can practice their own on certain procedures without it has been granted by Ministry of Public Health. Similar scenario prevails in the Canada as well. Canada has a different province, and different province and state have their own regulations and their own process. But this is what most relevant I found, and which was good to quote here. So in British Columbia province, the Medical Quality Office on behalf of British Columbia Health Authority grants the privileges. So again, no individual practitioner can practice their own what they know. It privileges and procedures, surgical, be it invasive, other cath lab or cardiac or neuro, those procedures should be privileges should be granted by the British Columbia Medical Quality Office. Now, coming to the US, again, privileges are granted by the organization, not by the health authority, but yes, there are guidelines which are laid down by the health authorities from the respective state as well. And similar scenarios there with the Australia, where privileges are granted by the Department of Health based on the Department of Health guideline. Now, two different extremes we will discuss and what prevails in India a little bit in detail, and what is good, which I found where I am based presently in Qatar. So in India, NABH standard has the privileging and credentialing process. What is expected when we talk about credentialing, and what is expected when in terms of privileging. So it says that hospital should formulate the committee to grant the privileges after verifying the credentials. And whereas in Qatar, there is a Department of Healthcare Practitioners, Ministry of Public Health guidelines, which has divided the different competency and privileges into 4 buckets for all the doctors based on their different level of qualification. So general core competency, which is applicable for all the doctors who are registered as an MBBS. Now that doctor can be MS, that doctor can be PhD, but this general core competency can be practiced by all the doctors when they obtain the license under Qatar. If you look into the core competency, again, this is being divided into 2 buckets broadly: medical core competency and surgical core competency. So any surgeon or any medical master's medical specialty, they can practice core competency without having any once they are registered, they can practice the core competency, what is listed. I'll be showing you in the next slide. Next is the core privileges. This can be practiced by the specialists who are in the respective field. Example, gynecology or cardiology or pulmonology, what they can do by default once they get the license to work in a Qatar. And last is the advanced privileges. That is only granted by Ministry of the Public Health for all the private sectors. So no one is allowed to practice the procedures which are listed under advanced privileges without getting permission from the Ministry of Public Health PHP department. Now, this is an example just to understand. I have quoted. So first on the left-hand side upper corner is the general core competency. So like admitting the patients, admission history and physical examination. So basic things which any MBBS doctors are allowed to do. Below is the core competency only for surgical specialty scope. Anyone who is holding any surgical scope, be it a neurosurgeon, be it a general surgeon, be it a gynec obstetrician, or be it a ophthalmic surgeon, they are allowed to do this particular procedures. And next comes to the core privileges. So these are listed 13 procedures which if any specialist in Qatar who gets the obstetric and gynecology license after 2018, they can practice these 13 procedures without any restriction. So if there is a gynecops doctor or there is any neurosurgeon, they can practice general core competency and core competency. And for example, for obstetric, I have quoted this 13 procedures which any doctor can practice in Qatar once they have the specialist obstetric license. Now, you might be surprised to see here there is no cesarean section, there is no normal delivery, there is no laparoscopic surgeries, there are no open surgeries in the list of this 13. Yes, so those all comes under the advanced privileges. So if anyone would like to do even normal delivery or even cesarean section or even any laparoscopic surgery, they have to apply for the advanced privileges. And advanced privileges, when we apply the to the Ministry of Public Health committee who interviews the doctors and reviews his credentials, logbooks, and past experience and recommendation. And based on those recommendation, reference, and experience, privileges are granted. As I told you, it can be a cesarean section, it can be any open or laparoscopic procedure. So likewise, for each specialty, core privileges are defined, advanced privileges are defined. So core privileges can be practiced by all the doctors, and advanced privileges can be practiced only if they get a permission from the regulatory bodies. Now, in general, if we see how to grant the privileges, this we have spoken in a Qatar context, but in general, how to grant the privileges. And all of you are the students, and probably in 1 or 2 years, you will be going on the floors. And broadly, the and majority of you belongs to the medical background. So it is essential that everyone knows on what are the basic principles are considered for granting the privileges in principle and in a typical scenario. So privileges are granted based on the regulatory guidelines, if available. If there is no regulatory guideline, we refer to any accreditation guideline. And if accreditation guidelines are also not available, we refer some good reference, evidence-based reference, and we adopt that practices to grant the privileges in organization. Now, on what basis we grant the privileges? I would like to reiterate here: qualification, registration, where you are allowed to practice. Now, in case of India, different state requires their respective state registration as well. So Maharashtra doctor cannot go in Gujarat or Karnataka and start practicing. He has to have a respective state registration. So he might be qualified, but if registration is not there, he is not permitted to work as per the law and regulation. What training and experience he is having, it should be correlated with the procedural logbook, how many procedures he has done. And it is very important, the number of procedure as well while granting the privileges. And I would like to quote good example in British Columbia, in Canada. They have even defined the number of procedures minimum required to grant the privileges. So, for an example, if I have not done 100 endoscopies every year, I will be not getting my privileges during next review cycle, because I don't have adequate number to retain my competency. And if I not have performed any procedure at all, then privilege can be revoked completely, because I have never done that procedure in last 1 or 3 years during the review time. Or it can happen that they may put it under the supervision, that you can perform the endoscopy, but you can perform under supervision because you have not done adequate number or you have not done at all. So that numbers are also important, but yes, there is no standard guideline across the globe that what are the minimum number of procedures required to renew the privilege or to review the privileges. And of course, last but not the least, along with the number of procedures, the skills what physician is having is equally important, and in terms of how complication rates and so and so. And last but not the least, yes, person is qualified, person is having experience, and person is having good recommendation and reference. So should we give a privilege? Okay, I would say no, until unless our infrastructure or scope of the services hospital meets the requirement for particular procedure. If we are granting a privilege for surgeon to do a high-risk surgery, so do we need to look into the infrastructure what organization is having? If we don't have ICU setup or any blood bank support or any laboratory or any radiology support, are we doing right by granting the privileges for doing the high-risk surgery? So I would say no, until as our infrastructure also should support what privileges we are giving to the patient. If we want to do the bypass surgery, we need to have a backup for the blood bank and ICU and anesthetist and 24/7 critical care specialist or anesthesiologist who can take care of the patient after surgery. So yes, we need to look into those aspects also, not qualification and experience is adequate. Infrastructure where person is working should support his practice. Here I would like to take another poll. Question is here. Cardiothoracic surgeon with CABG mortality rate of 2%, it is safe to allow him to continue to do CABG surgery? Yes or no? Okay, I think we have adequate responses now. So we'll end this poll. And again, we have here 63% who are saying yes, we should allow him continue to do surgery, whereas 37% of participants have said no, we should not allow him to do surgery. Now it's good. Now from the both the perspective, it is right. But yes, how we are benchmarking this 2%, that is most important. Now it is whether that 2% is acceptable or it is not acceptable, that need to be defined by the organization. Now I'm coming to that, how privileges, we have done the credentialing, we have granted the privileges. Now person is performing the procedures and surgeries and non-invasive, be it invasive. Now how it is important whether we allow him to continue to do that or not, and how we judge whether it is safe to continue or not. Now here, moving to the next slide, monitoring of the privileging is also important. We have granted, yes, he's qualified, he's having adequate experience, he's skillful, but ongoing professional practice evaluation is essential to monitor. If not, then what will happen? I've quoted in my previous slide Dr. Death, Dr. Christopher, who has harmed almost 33 patients out of 38. And after 2 years, it was brought into the limelight. Yes, significant. He is not safe to practice. He is not safe for the patient because of the past adverse events. So how we do that? So ongoing professional practice evaluation is very important, and how we judge whether we continue allow that practitioner to perform, or shall we suspend his privileges or put it under observation or revoke the privileges. So how to do that, and how we monitor on what from which corner we should start. So these are the some, this can be the some of the criteria, like low volume surgeries is very essential to monitor, because doctor is not frequently doing. So very likely that adverse event may result of, because of when we do less number of procedures, we lose the skill, and when we lose the skill, likely it may result into the adverse event. It is as simple as that. I'm driving a car once in a year and I'm driving a car daily. It makes a lot of difference in terms of skills. Now, another criteria can be the high risk procedures. Now, it can be liver transplant, it can be bone marrow transplant based on the size of the hospital, or it can be a simple open laparotomy surgeries for a smaller center. Now, that can be the high risk definition for different centers, or a high cost procedures like liver transplant, bone marrow transplant, renal transplant, or any other such cases. Or there are any problematic areas and procedures which requires attention and focus. So based on this different either low volume, high risk, high cost problematic area, the organization must define the measures or indicators to monitor the performance on an ongoing basis based on the reliable data. And again, to benchmark it. Now, I'm going to the previous slide back, whether 2% mortality in the bypass surgery is acceptable or not. Now, Cleveland Clinic data says 0.9% mortality is the benchmark for them. So for 2%, it is acceptable for my organization. We have to decide either based on the internal benchmark, or we have to benchmark it with the national standard if available, if not with the international, and then decide whether 2% mortality is acceptable or it is not acceptable, and should we act for suspending or monitoring the privileges, or we revoke those privileges. So these are the criteria which can help to judge or monitor the performance of the physician. So ongoing professional practice evaluation is very essential on this note. Now, we have granted the privileges, we have monitored, but how frequently we should review as well, whether what we have granted is whether we should continue or we should discontinue. So if we go for as per NABH guideline, this is annually we should review the privileges based on the 5th edition. Once in 3 years as per the JCI 7th edition guideline, but 3 years and 1 year may be the big gap sometime. And again, I would like to quote Dr. Christopher's case, 2 years and almost 33 patients out of 38. It's long, so it's long time. So ongoing evaluation helps in monitoring the situation on a periodic basis, and that can be the basis to continue and revoke, continue, or whether we should look into the privileges of the doctor. So ongoing evaluation really helps in an ongoing monitoring of the performance of the physician. Now, what challenges we face in most of the Indian context and in general as well? If wherever guidelines says that organization can grant the privileges. Now, lack of expertise and specialty evaluator. Now, if there might be a small hospital where there is only one cardiothoracic surgeon, now who should evaluate him, whether he is fit to perform the cardiothoracic surgery or not? Because there is no other expert physician available with a similar specialty in the organization. So this may be one of the challenge which organization may face. And in India, we have a lot of small hospitals which is manned by one doctor, 2 doctors, or 3 physicians, and they are singly manned, and they might not know what they should not do because of various reasons of lack of understanding of the adverse event, which is resulting a certain time we accept it. Okay, this can happen. This much mortality is acceptable. It may be 3% or 5% of CABG. The physician who is working alone may accept that 5% is acceptable. But do really it is safe until they don't introspect and someone is not able to monitor, say that this may not be, this may continue and may result into the patient deaths and harm. And last but not the least, business dependency. I'm dependent too much on this physician, and if I don't allow him to do this procedure, he may leave the organization, and that may result in conflict of interest and ego issues within the organization and between the physician. But yes, these are the challenges and which compromises the privileging processes in many of the places which I heard and during my past experience. But it has a lot of impact on the patient and mortality rate, complication rate, if we continue to do so without this. And I would like to quote here example that no physician in healthcare or no healthcare practitioners, in fact, be it a nurse, doctor, come to healthcare to harm the patient. No one does this. But what happens if we look from the Johari windows perspective, which we have learned in our management schools, that is the blind self, unknown to others and unknown to self. So blind self is information. I don't know what I don't know, but other knows. So this here, peer or ongoing performance monitoring or management can guide the physician if something is going wrong, if we look from this perspective. Whereas this is the most dangerous hidden part of unknown self. Information about you, neither you know or neither other knows. So this makes area completely gray, and this can result into the serious problem if the conscience doesn't work and doctor work out of consciences and goes back to back harming the patient, like what Dr. Christopher did. So I don't know which pocket we should put here, but yes, he was blind self will be the appropriate, because peer was aware of it, management of our was aware of those situations, but he continued to do what he was doing. but ultimately court convicted him because he was working in the conscience. That's what we told. Now, what is the organization responsibility? There are last two slides. We are running on the time, so I'll take it quickly. So, in Indian context, if we see what is organization responsibility, be it a solo hospital or it be a corporate hospital, as per the guidelines which is available in the NABH, that have a medical professional permitted by the law in the organization, verify all the information about the medical profession, grant the privileges based on the qualification, training, experience, and registration required by respective state or agencies. It is important that we communicate the privileges to the physician. If he doesn't know, he will not practice what he is supposed to do. He may go out of the limited privileges or what is not defined. And also it should be known to other relevant department. Like if we are granting a privileges for surgeon, minimum at least operation theater team, be it anesthetist, be it a surgical team, peer surgical team or nurse should know what surgeon is allowed to do and what he is not allowed to do, and provide the ensure that physician is providing the services only which they are privileged for, and most important that monitor the performance on ongoing basis. We should not wait for a long time where damages happen significantly and then we realize yes, something is wrong and we need to look into. So ongoing monitoring is very essential, and where we get a lot of success. Now, last but not the least, I would like to quote here, which is most difficult part is the privileging, yes, but determining the competency of the physician to provide high quality, safe patient care is one of the most important and difficult decision an organization must make. A lot of time, as I told you, business conflicts are there. There are egos issues. There are lack of expertise within the organization to grant the privileges and liberty which we are having. That organization can decide what privileges to be granted by the organization. There are a lot of good practices which is quoted. There are various countries, like one good practice I found in the Saudi Arabia, that if you don't have expertise within the organization, if you are granting the privileges for urologist, if you don't have urologist in your hospital, you should appoint from outside. And but make sure there should be a similar specialty doctor who can evaluate the particular specialty doctor before we grant the privileges or while granting the privileges. So those things are very challenging, but yes, it need to be done in interest of patient safety, in interest of organization, and to reduce and manage the risk of the getting patient harm. And overall litigation may results, and every year millions and billions of dollars are being paid for litigation on such credentialing and privileging issue. With this, I would like to thank you, and I'm open for any questions.
Thank you so much, sir.
Thank you.
So we do have a couple of questions in the chat box. The first one goes like assessment of patient safety from the patient perspective.
Yes, it can be done, but it is very challenging with the knowledge which patient is having. So we need to consider the healthcare literacy, what patient is having. Adequate healthcare literacy is required to look the patient's safety from the patient safety perspective. And it is very challenging. It is still okay to do it in urban, but where we go into the rural and semi-tier 2 cities, it is still very challenging. Patients are not aware on what is happening to them. So at that point, taking view from the patients and assessing the patient safety from patient view, it may be really challenging. But yes, it is coming up. And in coming days, more and more patients are getting more and more educated, and this will help actually in reducing the harm. And it is always proven patient perspective. If we take it, definitely improves the quality and care process.
Thank you, sir. Dr. Shreya, would you want to ask the second question?
So there is second question, sir. The question goes like how to address the challenges related to credentialing in remote areas in the primary hospitals.
Yes, so as I mentioned in my slide, it is really challenging, and specifically when there is a solo or 2-3 doctors who are working, where it is equally important. It is important definitely to verify the credential of physician, but also equally important to verify all licensed staff privileging, be it a nurse or technician. Yes, central repository is helping, like Medical Council of India website is there to help us to verify the credentials in terms of qualification. But yes, verifying the experience and the reference still remains the challenge for the smaller organizations where they don't have much of the resources to do. So would recommend to take a help from the authorized and I don't say authorized, it is credible outsourcing agencies which helps in primary source verification of all the documents, and that will help overall to ensure patient safety and we get the correct information which may not be possible for the remote smaller setups to do individually or themselves.
Thank you, sir. So we have one more similar kind of question. It goes like, do you feel that behavior and attitude towards healthcare professionals affect patients' safety?
Yes, of course it happens. And if we go from the doctor's clinician perspective, there is we call it as A, B, and C. So attitude, behavior, and competency. So competency comes last. So attitude and behavior matters a lot from the patient perspective. So all the clinicians are expected to work based on this algorithm ABC, that is attitude and behavior, and competency comes last.
Thank you, sir. So the next question is how to address the challenges sorry, sir. What are some tools to measure medico-legal significance? Is there any tool for that?
There are, as if I'm not understood, tool to measure medical legal cases.
Yes, sir.
No, there is no as such. I am not aware of any such tool, but yes, we learn from the landmark cases what has happened in the past, and we do measures in our organization based on the past learning, be it medical legal case which is resulting in other organizations.
Okay, sir.
But there is no as such tool I remember or I come across which help us to monitor the medical legal from the medical legal perspective.
All right.
So we have Bhargavi with us, and she wants to know what is the future of patient safety and the advancements which you feel should be endorsed to increase the quality of patient satisfaction.
So one grassroots problem or grassroots solution, both are same, is the culture of safety within the organization. If there is no culture of patient safety, it's whatever we do at the grassroots, it's not going to yield the results. So it is very essential that we improve the culture of an organization where people are open to speak and talk about the patient safety. Like Dr. Christopher case, where nurses have voiced about the incompetency about the doctor, but it was been not taken by the board or the director or owners of the hospital too seriously. So grassroots problem remains in the culture, and that is the only solution. We improve the culture. Now, how we do that? So it comes from top to bottom. Culture doesn't go from bottom to top. So it is very important to have a commitment from the governing and leadership team to improve the culture, and then it goes to the managerial cadre, and then it goes to the ground staff level. So always, if there is a commitment from the top to improve the culture, definitely we can yield a good results, and we can definitely improve the patient safety from this angle. And that is the global presently challenges, and every organization is striving to improve the culture within the organization where staff and the team is able to speak openly and raise the patient safety concerns among the seniors and the lateral lines.
Thank you, sir. So next question is, what major things you think Indian healthcare delivery system lack when compared to that in UAE or Qatar?
As I told you, no system is good or no system is really bad because every country has their own challenges, their own problems, and their own solutions. So we cannot cut paste any good practices from Qatar to India, or we cannot take any good practice from India to Qatar. We have to work on the context where the problems are different, solutions are different, and where we are struggling. So yes, all the countries are doing best. there are a lot of differences, as I told you here. Even a gynecologist cannot do the normal delivery also. Whereas in Indian context, anyone who is qualified as a gynecology from day one, they are qualified to do the normal deliveries or a cesarean section. But it depends on the country's priority. What is important? If we implement similar system in India, it may not work because we are already a lack of doctors. We don't have infrastructure and physicians in the rural and places, and if we curtail this practice, we implement such practices, it may further deteriorate our healthcare system. So whereas in Qatar, the priority is on the maternal and child health, it is one of the topmost 7 agenda on the National Health Strategy 2018 and 2022. They want to boost maternal and child health, so that's why they are very probably that's the reason they are putting so stringent criteria to even grant the privileges to that physician is fit to conduct the delivery. So it depends on the national agenda, and I always believe no one system is best. Every system, if you look from their perspective, it is good and it is evolving. No one system was good and is good. It is evolving and it will keep evolving based on the need of an hour. So again, very important that where we are, we should keep elevating ourselves in a possible manner. We cannot jump directly from A to Z. We have to run through that complete alphabet till we reach the destination. And always, whenever we do best, there is always a scope of improvement in whatever we do.
Thank you so much. So it was really wonderful answer. Yashashree, would you like to take up another question?
Surprisingly, we don't have any more questions. But
no,
yeah.
Bhargava has sent one question.
That is related to our courses, which we'll deal with on a personal basis. Yes. So with this, we have wrapped up our question answer sessions. If there are still any more questions, people, you can raise your hands. We'll wait for 30 seconds. And if there are still any questions, you can put it up in the chat box. Okay. So since we don't have any more questions, so it was lovely having you over with us, and it was really informative. And we would now like to call our very own Piyush Kumar sir to deliver the vote of thanks.
Thank you, Yashashree. Yeah, and thank you, Mr. Mahesh. It was really an interesting thing. I mean, a lot of things even I didn't know about this, honestly. And when you told about that Dr. Vinyam, so it reminded me of that movie, Catch Me If You Can. So the person keeps on living of a life, a doctor, a pilot, but nobody could actually catch him for a long time. So, but it's surprising to know that it really happens. I mean, and that in a Western world in the real life as well. And so it was really interesting to know about the privileging, how important it is for any hospital to do. And I think it's good for our students also. They would have learned a lot from this session. I hope everyone, right?
Yes, of course.
So thank you very much, Mr. Mahesh. And it's a privilege for having you here. We look forward for such more interactions. And whenever you plan to come down to Bangalore, please make sure that you do visit the campus and interact with the students in person.
Sure, Piyush, and thank you for this opportunity. And purposely, I quoted a couple of examples from Western countries because we always feel that where we exist is not good. And systems are not good, but every country has their own limitation, which I keep reiterating, and every system is good. And it is a people who have to run this, make the system work. If people doesn't work, system doesn't work. So that's the core at the end. So thank you very much for this opportunity, and it was lovely interaction with you and entire students and people, all the participants.
Same here. So people can share their queries with Yashashree and Dr. Shreya. We'll forward it to Mr. Mahesh, and you can just hear back from him.
So thank you, sir.
Thank you.
Thank you, sir.
Thank you, everyone. Thank you, Mr. Mahesh, once again.
Thank you. Bye. Have a good day.
Thank you so much. Have a good day.
Thank you so much, sir.